Okay, so good morning, everyone. First of all, I would like to thank the organizing committee for having me here. Once again, I'm Ingrid Malaluan, and I have just recently St. Luke's Medical Center, Institute of Pediatrics and Surgery. So I'm here to share with you the research paper which I did when I was still in training. So I completed this with the help of my supervising investigator, Dr. Julia Cho Aguilar, who is one of the well-respected pediatric gastroenterologists in our country. So my paper is about the assessment of the Alvarado scoring system in the diagnosis of acute appendicitis among the pediatric patients at a tertiary care medical center. So we all know that acute appendicitis is one of the most common surgical conditions affecting the abdomen in children and in teenagers as well. So approximately about 250,000 cases every year are diagnosed and treated with a 3:2 male to female ratio in terms of prevalence. So the lifetime risk for this is 8.6% among the male population and at 6.7% among the female population. It is more common among the adolescent patients and of course, also among adults in their 20s. So the gold standard for the diagnosis of acute appendicitis is the histopathology. However, of course, it is impossible to have a definitive diagnosis using the above test preoperatively. That's why several scoring systems have been formulated. So for patients with equivocal findings, CT scan or ultrasound of the appendix are available, both of them with good sensitivity, especially the CT scan, and also it is specific and less prone to operator bias. So here we go. One of the clinical scoring systems that I have mentioned is the Alvarado scoring system. So it is one of the most widely referenced in literatures. It was first described by Dr. Alvarado in 1986, and it is a 10-point clinical scoring system based on the analysis of the patient's signs, symptoms, and laboratory findings. So for the factors, it is made up of 8 with the popular acronym of MANTRELS, which includes migratory right iliac fossa pain, the anorexia, the nausea and vomiting, the tenderness in the right lower quadrant, presence of rebound tenderness, elevated temperature, leukocytosis, and neutrophilic predominance. So each of these were assigned 1 to 2 points, a total of 10 points. So for patients with a score of 1 to 4, it is said that they have low probability or unlikely to have acute appendicitis. For those with 5 to 6, they have equivocal findings. And for those 7 to 10, they definitely have or they have high probability of having acute appendicitis. So I have here the clinical management strategy for patients with suspected to have acute appendicitis. Those with scores 1 to 4 are discharged, and those with equivocal findings, they are admitted for further evaluation and management, and for those with scores 7 to 10, they are usually subjected immediately to surgery to avoid possible complications. So the good diagnostic validity of Alvarado score has been reported in diagnosing acute appendicitis, but some reports have found that Alvarado score alone is inadequate as a simple diagnostic test. Some studies even mentioned that the score showed poor results in the assessment of women because of probable gynecologic problems, and for the children and elderly patients because of age and other unusual presentation. So in one study done in Iran by Yagan and Associates, they studied a group of children and a group of adolescents. So each of them were grouped into 2 with a cutoff score of 7. They found out that among children, up to 92.4% of those who scored 7 and above indeed had acute appendicitis on histopath. However, only 15.6% of those who scored less than 7 had the disease. The sensitivity and specificity were low. Among the adolescents, they found out about 89 to 9% of those who scored 7 and above did have the disease, but only 3.9% of those who scored less than 7 had acute appendicitis. Sensitivity and specificity were at 61 and 63% respectively. A similar study done here in USA by Schneider and Associates, also they divided the groups into two. They found out that only 65.4% of those who scored 7 and above have the acute appendicitis, but up to 85.2% did not have the disease among those who scored less than 7. They also tried to get the negative appendectomy rate of acute appendicitis. So this is defined as the number or the percentage of people who are proven not to have acute appendicitis on histopath over the number of people who were really subjected to operation. So the rate was low at 7.7%. Still in another study, done in Egypt by Shrif and Associates, they tried to assess the Alvarado scoring system using the three groups, the original groups. So they found out that all of those who scored 1 to 4 did not have appendicitis. And for those who scored 7 to 10, about 75.5% of them were proven to have the disease. However, the negative appendectomy rate was very high at 27.5%. The sensitivity is, of course, excellent at 100, and a good specificity of 84.4%. In another study done by Escriba, they studied about 99 patients, and same with other literatures, it is most common among the male population. The negative appendectomy rate was low at 4.5%. And lastly, in a study done in Italy, with a total of 156 patients, the negative appendectomy rate was acceptable at 9.5%. So in the Philippines, and I think also in other countries, I believe that when a clinician is faced with patients presenting with acute abdominal pain, the utilization of any clinical scoring system is not that well utilized, especially in non-teaching institutions. So with that being said, this study will provide medical and other healthcare professionals a basis for evaluating the applicability of the Alvarado scoring system as a clinical tool to assess patients presenting with acute abdominal pain. So if proven helpful, it could distinguish acute appendicitis from less urgent conditions in a rapid, cheap, and safe manner without the need of unnecessary, expensive, and potentially harmful ancillary procedures and inappropriate appendectomies. So currently, only a few studies involving the pediatric patients are available. And I think in the Philippines, there is still no published study similar to this. So my research aimed to evaluate the Alvarado score as a clinical tool in screening for acute appendicitis. My specific objectives were as follows: to review the demographics and clinical course of the admitted patients with possible acute appendicitis, to determine the Alvarado score of the patients who underwent surgery and those who were not operated on, and correlate it with the histopath results and final diagnosis respectively. Also, to correlate the Alvarado score of the patients who underwent imaging studies like the CT scan and ultrasound with the results of the said ancillary procedures, to determine the Alvarado scores of the patients initially considered to have acute appendicitis, and lastly, to determine the negative appendectomy rate among patients who underwent operation. So my study is a retrospective and a descriptive one. It was conducted in St. Luke's Medical Center, which is a private tertiary care hospital in the Philippines. So involved in this study were patients that were seen in the emergency department from January 2012 to June 2013. So this research was reviewed and approved by the Scientific Research Committee and the Ethics Research Committee of the Institute. Included in my study were patients 80 years old and below who were brought in the ER because of acute abdominal pain, assessed using the Alvarado score, considered to have a possible acute appendicitis, and subsequently admitted for further evaluation and management. So for patients who cannot express their symptoms, maybe because of age or any disabilities, assessment using the Alvarado score was based on the observation of the parents or guardians. Excluded in my study were as follows: patients who have imaging-confirmed diagnosis of appendicitis on arrival to the ER, those who were already treated conservatively with antibiotics and/or pain medications, those with incomplete documentation in their case sheets, and those who were discharged against medical advice after being admitted at the wards. For my operational definition, acute appendicitis is the evidence of appendicitis based on histopath findings. When we say not acute appendicitis, it is the absence of appendicitis based on histopath findings, course in the wards, and/or ancillary procedures done, if any. Once again, the negative appendectomy rate is the incidence of no appendicitis based on histopath results among patients who underwent appendectomy. So the records of the patients were treated and reviewed. The demographics, clinical course, and ancillary procedures, if any, were noted. Among the involved subjects, they were grouped into three. Under Group 1 are those with scores 1 to 4, with low probability of the disease. Group 2 are those with equivocal findings or doubtful but potential candidates suffering from acute appendicitis. And lastly, Group 3 are patients with scores 7 and above, with high probability or likely to have acute appendicitis. Among those who underwent surgery, their scores were compared with histopath results. So we say that it's positive appendicitis if proven in their histopath. Also, the negative appendectomy rate were noted. Among those who were not operated on, their scores were compared with their final diagnosis based on ancillary procedures, if done, and of course also based on their clinical course during their hospital stay, as assessed by their attending physician. The alternative diagnoses were noted. So a total of 82 patients were included in my study, and similar with other literatures, it's more common among the male population at 55.1%. Age range was 4 to 18 years old with a median of 11 years and a mean age of 11.24. I have here the distribution of patients according to the Alvarado score. And here, the distribution of patients based on the three groups of the Alvarado score. So 24.4% of patients had scores 4 and below, 31.7% had equivocal findings, and 43.9% had scores of 7 and above. So for the results, a total of 20 patients in Group 1, or those who scored 1 to 4, were noted, and 4 of them had progression of symptoms. 3 of them underwent ultrasound or CT scan despite the score of 1 to 4. So this is based on the discretion of the attending physician. These 4 underwent appendectomy, but only 3 were noted to have appendicitis on histopath. 16 of them did not have any progression of symptoms and were given and managed accordingly based on their alternative diagnosis. Among the 26 patients under Group 2, those with equivocal findings, a total of 3 did not have any progression of symptoms and were managed accordingly. 13 patients underwent appendectomy, and that was based on the progression of symptoms or the findings in ancillary procedures. Of the 13 patients, 11 had positive acute appendicitis on histopath. Lastly, among the 36 patients under Group 3, 30 patients underwent appendectomy. So despite the score of 7 to 10, 6 of them underwent ancillary procedures with positive signs of acute appendicitis. Of the 30 patients, 28 had positive acute appendicitis in histopath. 4 patients had regression of symptoms after being admitted at the wards, and 2 of them had negative results on CT scan or ultrasound. So they were not operated on and were treated based on their alternative diagnosis. So here is the cross-tabulation of the Alvarado scores and the number of patients with and without acute appendicitis. And as we could note here, the Alvarado scoring system is helpful in terms of assessing patients with positive appendicitis, with up to 77.8% noted to have the disease among those who scored 7 to 10. So this is quite comparable with international studies and even higher compared to the study done here in US by Schneider and Associates. Then it is also helpful or valuable in diagnosing patients clinically with up to 85% noted to have no appendicitis in histopath for those who scored 1 to 4. For patients who scored 5 to 6 or those with equivocal findings, it is prudent for them to be admitted and to be subjected to CT scan or ultrasound so that they could be managed properly and immediately. Here I have the trends in predicting an accurate diagnosis for acute appendicitis and non-acute appendicitis. So the blue bars represent the patients with Alvarado scores of 1 to 4. The yellow bar, those with 5 to 6 scores, and for the red bars, patients with scores of 7 and above. So as we could see, among patients with acute appendicitis, there is an increasing trend of diagnosing acute appendicitis with an increasing score group. So among those without acute appendicitis, the opposite is observed with a decreasing trend with an increasing score group. So using the chi-square test for independence, it was found, and using the 1 degree of freedom and a significance of 0.05, it was noted that the p-value was less than 0.05, giving a strong correlation between Alvarado score and the presence of acute appendicitis. So here I have the alternative diagnosis of patients who were not operated on. And as you can see, the most common is functional constipation, followed by mesenteric lymphadenitis and gastroenteritis. Here is the histopath findings of those who were operated. And a total of 47 patients underwent appendectomy, of which 42 were confirmed to have appendicitis on histopath, giving us a low or somehow acceptable negative appendectomy rate of 10.6%. So in order to compute for the sensitivity and specificity of this study, I tried to divide the patients into two with 7 as the cutoff point. So the sensitivity was not that good at 67%. The specificity is somehow acceptable at 80%. And the positive and negative predictive values, well, they are not high, but somehow acceptable. And as a conclusion, the Alvarado scoring system provides useful diagnostic information in the assessment of patients with acute abdominal pain. So it is helpful. It is a helpful practical screening procedure so that it's, of course, simple, fast, cheap, and safe. It could not be used exclusively, but it could serve or it could be of assistance in categorizing patients for discharge and for admission for further evaluation and or management. So those with scores 7 to 10 should be admitted and undergo appendectomy immediately to avoid complications. Those with 5 to 6 Alvarado scores should also be admitted for further evaluation, and they might require additional tests like ultrasound or CT scan to make an accurate diagnosis. And lastly, for those who scored 4 and below, they can be discharged with a general advice to seek medical attention as indicated. So this study carries some limitation due to inherent flaws of retrospective studies. A total of 8 patients who scored 7 to 10 were subjected to CT scan or ultrasound, and because of that, it affected the negative appendectomy rate of this study. It would, however, be unethical for the attending physician to subject a patient unduly to surgery with further information available on imaging studies. So as this is a retrospective study, there was no systematic procedure for the decision on imaging studies. For this reason, it is recommended that a prospective study be carried out, identifying the standards for requests for imaging. And in addition, it is recommended to increase the number of subjects to be involved in this study to have a more conclusive results. Thank you.
Any questions? I have a question. Did you stratify by age at all to see? Because kids who are younger, sometimes it's harder to diagnose. Acute appendicitis is it would the sensitivity or specificity be higher with the Alvarado score in older kids versus younger ones?
Well, I didn't try to stratify the patients considering of the population, the small population that I have. But according to one study done in Egypt, they tried to stratify patients, children, and the adolescent group. However, both of them had low sensitivity and specificity.
How many times did you do the evaluation using the scoring?
In my study, Doctora, yeah, it is a retrospective study, but for the inclusion and exclusion criteria, the patient should be admitted or seen at the ER. And the one doing the Alvarado scores include the pediatric consultant on duty and the senior pediatric and surgical resident on duty at the ER.